Hello, exchangers of the gas. Welcome to the Gas Exchange Podcast, where we talk about respiratory critical care. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. This podcast is part of our efforts at Inspire Respiratory Critical Care, where we provide expert panel discussions, pearls, virtual classroom lectures, and other initiatives. You can find our podcast on the YouTube, Spotify, and Apple podcast channels. On our website, www.inspire-rt.com, you can find links to our past recordings and many other resources. My name is Keith Lamb, and I'm the host. I'd like to welcome my co-host, Thomas Perino.
Hi there. Good morning.
And today's guest, Dr. Nicholas Hill. Nick is a highly respected clinician, a prolific researcher, and pulmonary critical care expert. We are fortunate to have Dr. Hill here with us today. What an honor it is to have you, Nick. Welcome, Nick. Can you tell us a little bit about yourself?
Sure. Well, I'm located in Boston, where we're having a sunny morning, and I apologize if anybody's getting glare. We've got a little cloud cover right now. I am the past chief of the Division of Pulmonary Critical Care and Sleep Medicine here. Stepped down a couple of years ago, but I'm continuing to practice theoretically half-time, but half-time jobs are never half-time. And I'm continuing to do research, clinical trials, and some physiologic research on some non-invasive ventilation gadgets. And I have been active with the American Thoracic Society. I'm a former president of that. I also have a clinical interest in pulmonary hypertension, which is kind of a parallel interest with the non-invasive, but I don't think we'll get into that today. So let's leave it at that, and we can go from there.
All right.
I should mention I've had a long interest in non-invasive ventilation, going back to my fellowship, which is now, I guess, about 45 years. Oh, it's remote, a little more than 45 years. So a lot of water over the dam.
Well, welcome, Nick.
You were
We really
basically
appreciate
there
you.
you were there when it started, essentially.
Yeah, pretty much.
Yeah. So Nick and I have known each other for quite some time. We've presented at a handful of conferences together. Thomas also has worked with Nick, so we go back. When I think of Dr. Hill, I think non-invasive support, and that used to, in my world, in my mind, non-invasive support encompasses more than one modality, more than one thing. When I talk about non-invasive support, I include bilevel ventilation, continuous positive airway pressure, and now in the recent years, I also include high flow nasal cannula. Dr. Hill, can you just kind of run us through why don't we talk about the historical perspective of non-invasive support?
Sure. Well, as we were saying a moment ago, I go back pretty much to the beginning of what we do with non-invasive today. My first involvement with non-invasive ventilation was a pneuma belt, and it was during my fellowship, and a young woman who had a muscular dystrophy had been admitted with an acute onset of respiratory failure after she'd gone to her primary care doc complaining of problems with sleep, and he gave her a sleeping pill. Well, it turned out she was in hypercapnic respiratory failure, and a sleeping pill added to that is a catastrophe, and this is what happened to her. And she did initially get intubated, but my attending at the time, Gordon Snyder, a very well-known clinician in his day, decided that we should try a pneuma belt, which is an inflatable corset that fits over your abdomen, and you hook it up to a positive pressure ventilator, and you blow air in, and the corset expands and presses on your abdomen, forcing your diaphragm upward as long as you're sitting. And then when it deflates, gravity pulls your diaphragm back down. And I kind of call it a diaphragm pump because it does that repetitively. And you can support people with hypercapnic respiratory failure with it. It's generally not used for acute crises, but in this case, it actually allowed us to stabilize this patient, get her extubated, and she continued using it. I kind of lost follow-up with her, but that was my first introduction, and I thought, this is the coolest thing, because that didn't require invasive ventilation. And so when I came to Tufts, we had a rehab center where I used a number of different devices. We had patients at home on iron lungs, a negative pressure ventilator, which works by decreasing pressure around your thorax and abdomen. And when it goes negative, it draws air into your lungs. And when they drop the negative pressure, then your lungs exhale by passive forces. And there were a few other negative pressure devices, something called a pneumowrap that uses a rigid cage inside a basically a impervious jacket. And again, you use a negative pressure pump to create intermittent negative pressure. The difference between the iron lung and it is that although the iron lung is much more efficient in applying negative pressure, it also weighs 650 pounds. So it's not something you can throw in the trunk and bring the trip for the weekend. Whereas the Dupa wrap, you can. Negative pressure pump was kind of heavy, but nowhere near 650 pounds. You could throw it in the back of your trunk. So anyway, that's where I cut my teeth on non-invasive ventilation during the early 90s. And I wrote an article that was published in Chess in 1986, which described all these so-called body ventilators. That was the title of the article. They asked me for some photographs of these various devices, and the cheapest and most available subject, you could argue about whether I was best looking available candidate or not, but still in the internet, if you go on, if you Google pneumobelt or pneumowrap or even iron lungs, I'm there from
Yeah,
30 something
there
years
he is.
ago. But anyway, in that article, I mentioned that there's this thing called non-invasive positive pressure ventilation that seems to be moving in on the field and taking over from these body ventilators. And that's exactly what happened. By the end of 1980s, we had made a complete shift, and we kind of put those other devices into the closets where they were collecting dust, and non-invasive positive pressure took over. And the technology was borrowed really from the technology developed to treat obstructive sleep apnea, positive pressure devices, and then the development of the masks, which was a very important development. During the early 80s, we had all these, Rube Goldberg devices that people made in their garages. And when the larger companies started consolidating Respironics and ResMed, mask technology came along. And that was so important because non-invasive positive pressure ventilator doesn't work well if you have a mask that people simply can't tolerate.
Yeah, it's all about the interface.
Exactly.
Clients.
So my initial introduction to non-invasive ventilation was via chronic respiratory failure. These people I had at home on iron lungs and these other devices saw the benefit of using these devices. They were much more portable. We had been doing a research project with Respironics on COPD patients on non-invasive positive pressure ventilation, and they had provided us with a number of the original BiPAP prototypes. It didn't even have a assist mode. It had a timed backup rate, but it couldn't be triggered. And we used that on COPD patients in whom it didn't really work that well. But I had a number of patients with neuromuscular diseases who, when they heard about this thing, they wanted to try it. And so I gave them BiPAPs, STs, the prototype, and they did great on it. We had one person who took a vacation to Hawaii and put it up over the luggage bin, carried it on, and was able to do that. Whereas even though she had been on positive pressure ventilation with us, you probably remember the LP10, I'm sure you do, which was kind of a clunky device compared to, say, a BiPAP. So that it was so much more portable. And we did some research projects, published some articles on this, and demonstrated that, number one, it's a pressure support ventilator. BiPAP was a pressure support ventilator. That was an article in Respiratory Care, I think in around 1990. We published an article on our patients with chronic neuromuscular or chest wall diseases, and that was in the Blue Journal during the early 90s. And then we subsequently, the mid-1990s, published an article on its use in the acute setting, where we showed that it was particularly effective for people with COPD and hypercapnic respiratory failure, and not so much in hypoxic respiratory failure. And that article came out a few months before Laurent Brochard's Signal article published in the New England Journal,
Hmm.
where he had substantially more patients than us, and it was his was a better article, I have to admit.
Mhm.
So we
Mhm.
our article has been largely forgotten, but this is where the start of non-invasive ventilation and its infiltration into both the chronic setting and the acute setting was initiated. And I need to give credit to a whole lot of people. The Europeans had a lot to do with the proliferation. Canadians, all over the world, this took over. And I was just
Hmm.
lucky to have a surfboard and ride the wave. You know,
Yeah, I think one of the things I find interesting when I've heard some people, I can't remember who said this, so I apologize for not referencing the person, but they had mentioned the fact that Laurent Bouchard's paper in New England Journal of Medicine that has become sort of this pivotal moment with COPD management with non-invasive ventilation in the acute care setting. I mean, it had less than 100 patients. I think it was like in the
80,
80s, maybe. Yeah, it
80
was like
patients.
so very, and like people were just commenting like, "Good luck finding an article published in New England Journal of Medicine now where the outcome is mortality and there were 80 patients." But the signal was clear, right? It was one of those things where it's like this is clearly better than the alternative. So
Yeah,
no one questions the authority of the results of that paper, but it's funny trying to find a paper with a mortality benefit now in New England Journal of Medicine with less than 100 patients. It's just not it doesn't exist.
Mhm.
well, our article ended up being published in the Blue Journal, which is not a bad place, and
Fantastic.
we had a little over 30 patients. We did try the New England Journal first. They didn't buy
They're like, "No,
30.
we need at least 60 patients." Now it's more like, is there over 400 or 500 patients? Then
Yeah,
I don't know. Yeah.
or more.
Yeah, exactly.
Yeah.
Yeah. Yeah.
A
That's
hundred
funny.
thousand isn't bad if you can do that.
Yeah.
Yeah,
Yeah. If you can handle that. And actually,
yeah.
while we mentioned that, I I must say, like, one of the hardest things I think with researching that specific patient population and various therapies, I'm referring to your paper. This is sort of a pivot, but your paper on using vibrating mesh nebulizers in the emergency department for acute I think it was acute hypercapnic respiratory failure. Was it asthma
That
or
was
was it asthma
asthma.
and COPD? Asthma, right? And, just and I'll have you comment on this, but I think we've gotten so good, not we're not the best, but we've gotten so much better at managing asthma that to do a study on asthmatic patients, the amount of time required to get a significant number of patients coming through your emerge that meet specific criteria has changed over the years. Would you admit? Would you
Absolutely,
agree? Yeah.
absolutely.
Yeah,
Yeah,
because your study was stopped early for essentially futility. It's just taking too long to get a good number of patients. And I imagine in the 80s and 90s when this therapy was first, not vibrating mesh, but like just when we were getting better at managing the acute, it just started to like as medications got better and better over the years, the number of patients coming to the emerge must have gone down significantly.
absolutely. COPD remained a fairly popular reason for ending up in an ED, and that's true today.
Yeah, it still is.
But
Yeah, I agree.
compared to the 90s, the occurrence of hypercapnic failure due to asthma in EDs is a small fraction, and it's because of these inhaled corticosteroids that we have and other, these biologics and other treatments we have for asthma, have to be either very unlucky or not very adherent or something to end up in an ED with acute hypercapnic respiratory failure with asthma. And for that reason, to this day, we don't have any adequately sized studies on the use of non-invasive or high flow in acute asthma in the ED.
Mhm.
Written about it and talked about it, and uh, I have a fair amount of clinical experience doing it. But as you say, you might not live long enough to get a few hundred patients
Right.
first clinical study.
Yeah, and it's unfortunate because we do really have like promising therapies, like interfaces have gotten better. The combination of high flow nasal cannula with non-invasive ventilation, like interchanging the two, like we have some good studies in patients that are in respiratory failure with hypercapnic failure, showing this like synergistic effect of when they're resting from BiPAP using high flow. And these sort of studies would it would be great if we could, extend that out to populations such as asthma. But as you mentioned, fortunate enough for the patients, they're not filling up emergency rooms at the same rate that they used to.
Right. On the whole, it's a good thing.
Yeah.
And I do advocate the use of non-invasive ventilation in appropriately selected asthmatics. I've had enough experience, so I don't need a randomized control trial to convince myself that there are patients who benefit, and you can avoid intubating patients with asthma. If you ask me to give you a large, you're all familiar with the Cochrane Library, I'm sure. The level of evidence that you need to get the endorsement of the Cochrane Library isn't going to happen in asthma.
Yeah, and I think this is likely why the 2017 guidelines for non-invasive ventilation, they don't recommend against asthma. I think they provide no recommendation just because there's insufficient evidence. And I think it's important that our listeners, if you're just getting into reading guidelines, to understand that, there's things such as a strong recommendation, which means further evidence is unlikely to change this behavior or this result. And then you have conditional recommendations where if you get enough papers, it could shift it one way or the other. And then and those are conditional recommendations for. And then you have conditional recommendations against, which again, evidence could shift it another way. But as for now, it's something you probably shouldn't do outside of research. But then you just have the no recommendations, and the no recommendations are the ones that don't really help so much. It's essentially saying that, hey, we understand that people use non-invasive for this group of people, but we have insufficient evidence to provide a recommendation on whether or not it's good or bad, and likely due to the significantly low numbers of all of these studies. So, so if you are someone out there that uses non-invasive with asthma, don't worry if guidelines don't support it. They also don't tell you shouldn't do it. They're just being neutral on the subject for now. But as you mentioned, Nick, you have years of experience using it. And this is what really guides people using it, is if they're in an institution where they have this experience and they have the knowledge and the understanding of when it's appropriate, when it's not appropriate, then you likely could do it quite safely and effectively. We just don't have large RCTs to push guidelines to saying, yes, these are absolutely recommended, whether it's conditional or strong.
Yeah, it's always important to keep in mind that guidelines are guidelines. They're not biblical. They're not carved into stone, and they change over time.
Mhm.
The no recommendation we gave for what we call de novo hypoxemic respiratory failure, people with acute pneumonias and hypoxemic respiratory failure, or ARDS, we gave no recommendation, as you said, Thomas. And one thing that occurred to me not too long after that guideline was published was I wrote some review article on non-invasive ventilation, and included the de novo, and made a statement about how there are circumstances where you would consider using it. And one of the reviewers said, wait a minute, you guys said there was no recommendation for it.
Yeah, that's not a recommendation against, though, right?
Exactly.
Right.
That was misinterpreted.
Yeah.
So you have to be
Yeah,
careful.
that's why I mentioned. Yeah.
No recommendation means literally no recommendation, not
Yeah.
for or against. And we
Exactly.
actually
It just means we're
spelled
not
out,
saying anything about it.
and the narrative part of the recommendation actually said what I said in the review article, which is there are circumstances where it would be reasonable to try non-invasive in people with hypoxemic respiratory failure. We just don't have enough evidence to meet the standards that would be necessary to make a guideline.
Yeah, and I think people need to understand that randomized controlled trials are set up in a way that they answer a question on whether randomly assigning patients who meet criteria to a therapy is good or not. And when these results are inconclusive, it doesn't mean that there aren't patients that might absolutely benefit from the therapy. It also doesn't mean there's not patients who would deteriorate very quickly with the therapy. So it's a matter of all the evidence says, and the reason why we're sort of standing back and saying we don't have recommendations is that we don't have clear evidence that randomly assigning it to patients who meet this criteria is something that you should be doing. And I think with hypoxemic respiratory failure, I know when I graduated, I was under the mindset that, if they have pneumonia, we don't give non-invasive ventilation. And again, this was before the 2017 guidelines, even before the 2011 guidelines. So there was this, misconception that, we just don't do it for pneumonia. And then as you read on, you realize there can be actually quite successful management of these patients. But what is clear in the literature is that there are many papers on risk factors for failing. And I think this is where the disconnect happens, is that you can be successful in these types of patients, but there are very specific risk factors that have been well identified in the literature that if you're not reassessing in 1 hour, 2 hours, and looking at specific factors or even pre-factors, right, like that maybe make them more at risk of failing, if you are not monitoring these patients closely, yeah, you could be on this side where you're probably just delaying intubation and perhaps this is harmful. Whereas if you're monitoring and things are actually improving and you're doing it in a short period of time, then yeah, it could be beneficial. So I think the risk factors weren't hammered home enough when I first graduated. It was just the patient populations where it says yes or no or maybe, and then not enough focus on like, hey, let's pay attention to these specific things. Go ahead and try it prior to intubation, but be very strict in your requirement for, or your threshold for intubation should be very clear, I should say, before you initiate it.
Yeah, I think anybody who's written about its clinical applications in the acute care setting points out the need to avoid delayed intubation. You know,
Absolutely.
once you pass a certain threshold, and no, one absolute no-no, I think, is when someone has septic shock and ARDS. That is not a situation for non-invasive. Just to make a few comments about the evolution of guidelines, I think this de novo hypoxemic respiratory failure, whatever you want to call it, category is an example of that because we did come up with a no recommendation in 2017. I'm on a guideline committee now, which is still in the process of formulating guidelines. So I can't say too much more about it. I bring it up because we are leaning toward probably a conditional 4 in, not it's carefully selected patients
Yeah.
with that form
And I
of.
imagine there's very clear suggestions on risk factors to pay attention to, probably because, or not risk factors, but like clinical signs and scenarios to look at. So that, because I think the more data we have, likely the more understanding we have of when this is not working and who it's not working for. Right.
And another point to make related to that is with the introduction of high flow, we now have a tool to use for hypoxemic respiratory failure that is supported by a fair amount of data. So when you write guidelines, you have to incorporate high flow into the discussion about hypoxemic respiratory failure. There was the FRAT article, the Florali trial that was published in
Mhm.
the New England Journal, I think 2015, which showed, a considerable benefit for high flow and better than non-invasive or standard oxygen. Although the main outcome variable, which was reduction in intubation rate, did not meet statistical significance. So, when I've discussed this article, I've had to admit that technically speaking, it was a negative study, but it showed a very impressive mortality benefit, both after ICU stay and after 90 days. And that really is what propelled it into stardom, so to speak. And the authors have been promoting the use of high flow and not using non-invasive at all. I think that's going a little bit far. And
Mhm.
as I mentioned, the guideline committee that I'm involved in is not going to say anything like that. They're going to say, conditional for both. And in fact, you mentioned you can use them in tandem. We
Mhm.
often do that. Non-invasive is clearly less well tolerated than high flow, and the combination of the two, you put them on non-invasive to the point of intolerance, you switch them to high flow.
Mhm.
We did a study published in the Journal of Critical Care that came out, I think, around 2019, just before the pandemic, which looked at the tandem use of high flow instead of standard oxygen during breaks from non-invasive.
Mhm.
So that what we were comparing was high flow to standard oxygen in combination with non-invasive. And we showed some benefits for high flow, as you might expect, compared to standard oxygen. So, my practice generally has been to use high flow instead of standard oxygen during breaks, whether it's for hypoxemic or hypercapnic, it still has a role. And, you know, another area of controversy that we've argued about on this guideline committee is the use of high flow for hypercapnic respiratory failure.
Right.
And here again, the guidelines dating back to the late 90s all said non-invasive for hypercapnic respiratory failure, especially COPD. I think that's still a good application of NIV, but it's possible that high flow has a role, and I think the evidence we're seeing emerging suggests that, but I have not yet been convinced that when people have severe hypercapnic respiratory failure with high work of breathing, that high flow works as well, because the ability to generate targeted pressures with non-invasive ventilation give physiologic advantages to the mode. You can cut down the work of breathing a little more effectively. So, with that exception, I would say uh, that the data supports the idea that for at least up to moderate COPD, high flow and NIV, well, the studies have looked at non-inferiority
Yeah. I was
compared.
just going to say there's a non-inferiority study looking at high flow's ability to lower CO2, and they found it non-inferior to non-invasive ventilation. But this is where the understanding of how studies are operated is important, because when you look at the amount of crossover, so when you look at how many patients end up requiring NIV, in like this the one study I'm thinking of currently, this non-inferiority study, they found, yes, it lowered CO2, but more than 50% of patients within 6 hours required non-invasive ventilation. So
Non-invasive
it's like,
ventilation, yeah.
don't throw the baby out with the bathwater kind of thing.
Exactly. Yeah. Was that the Renovate study you're thinking of? It was a
And
Brazilian study with like 1,700 patients or something.
No.
The
I'm
other
familiar
one
with that one.
is the Doshi.
So the Doshi one, yeah, the Doshi one is another one that I often I humor my audience sometimes when when I give talks on understanding research papers, because here's a paper where it says, oh, there's significantly less intubation when you use high flow or high velocity nasal cannula in all comers to the emerge, but when you look at the data, people on that therapy were also more likely to fail and require NIV. And when you look at the charts, you can see that the patients rescued with NIV, significantly low number of them required it. So essentially saying that, sure, at a glance, it looks like, because this is the intention to treat analysis, right? And I think a lot of people who don't read a lot of papers don't understand what intention to treat means. It essentially means that if the patients fail that therapy and they are successfully rescued, they're still kept in that group. So it can still make that group
mhm,
in general look like a very successful intervention. But when you look at, it's like looking at the fine print, right? You look at the fine print and you're like, a significant number of patients required NIV and it was successful at rescuing them. You have to understand that this kind of muddies the water a little bit in terms of interpretation. And
Right.
that's a perfect example of that.
Yeah, in the Doshi study, if I recall the numbers right, they had 3 crossovers from NIV to high flow
Yeah. But
or
then they had
high
like
velocity.
27. Yeah. And they had 27 crossovers in the other direction.
They all got intubated, and then in the other direction, there were over 20,
Yeah.
and
Yeah.
only 3 of them got intubated. So,
Exactly. Yeah.
how can you draw conclusions about that?
Oh, but you'd be surprised how many people draw conclusions
Well,
about that
they
paper.
did. In
It
that
was like
article,
particularly the
they
companies that make the devices
they
sometimes
said
draw
it's not
conclusions.
inferior.
Yeah, yeah, this is the problem of not understanding research, and then you walk by a booth at a conference and someone convinces you of the global results. It's tricky. Becomes a marketing tool for companies. It shouldn't result in someone saying, "Oh, I don't think we need a BiPAP in the emergency department anymore. Let's just equip every room with high flow or high velocity, and we're not going to need BiPAP anymore." That would be a huge misinterpretation of the evidence.
mhm.
Yeah, and it is the case that high flow has a dose response in terms of flushing out dead space and helping eliminate CO2, but I've seen it do pretty poorly in people with severe hypercapnia. I think encouraging generalized use in anybody who's hypercapnic because it can flush out dead space better is a fool's errand, because you are going to have people who are not going to respond well. And the difference is that when you have NIV and you have the ability to put pressure support added to the PEEP, you get augmentation of tidal volume and have the ability to enhance excretion of CO2 better in these severely hypercapnic patients. That's been my observation. Again, in the lack of well-designed trials looking at that specific population, I can't stand here and say the Cochrane Library is going to endorse what I just said, but that's certainly belief from my experience.
Yeah, there was another study. Just because you mentioned dose response, there's not only the dose for CO2, but there's a dose for work of breathing, it seems, too. There was a study published out of Thailand that showed work of breathing. So they compared patients who were already established on NIV for or hypercapnic respiratory failure in the emerge department. And then they transition them and they would do 10, 20, 30, 40, I think up to 60 liters per minute of high flow. And they were monitoring things like pressure, time product, et cetera. And they actually found a sweet spot with these COPD patients around 30 liters per minute of flow, rather than what we would think is like, oh, the higher the flow, the more effective it'll be at washing out. But we have to understand that when the flow is that high, if someone is breathing through their nose, there is some expiratory resistance to exhaling if they're not, just breathing out their mouth. They found a nice sweet spot for worker breathing around 30 liters per minute of flow. So I think when I read that paper, I thought to myself, I think we still need a lot of work in the COPD population because of their unique lung mechanics. There may not be an optimal flow that we think, oh, the higher is the better. For them, it's actually slightly, which seems counterintuitive. But when I saw that paper, I was like, there's a number of physiological
Yeah,
reasons why this might be, but
I don't think you can come up with one number for the sweet
for
spot.
for all patients, no, for sure.
No.
Right.
Importance of titrating, I think some people just initially they're like, oh, if I need to get rid of as much CO2 as possible, I'm going to start at 60. And I think that might be a bad approach for most patients, probably starting at 30. And then as you titrate up, if it seems the patient is uncomfortable, working hard, again, that tolerance of therapy, going all the way back to our comment on masks, the tolerance of the interface really is important for success of therapy.
Yeah, I think starting at say 50 is fine for hypoxemic respiratory failure because there are a couple of mechanisms, but one is by flushing out much of the anatomic dead space, you're helping to conserve FiO2 because the next inhalation is going to have a higher FiO2, and then the high flow also enables you to keep up with the inspiratory flow so that you don't get as much dilution with room air. So, flow is important in maintaining the oxygenation with high flow. With COPD, I think it gets a little bit more complicated because there is expiratory flow limitation in these people, and it will vary from patient to patient. But I think that probably is why these guys found a sweet spot. Just as we know in people who were vasally ventilated, if we give them too much tidal volume, we contribute to dynamic hyperinflation, and we can create problems. And I'm speculating now there may well be a similar phenomenon in people when you try to ventilate them non-invasively, where you could overdo it.
Yeah, they're
Yeah, I
definitely a
think
unique population. Sorry, go ahead, Keith.
I was just going to say, I think it boils down to the sort of the same thing in most of the interventions that we provide, and that is and so Nick, we like to kind of reel back a little bit and make a couple of observations that would help the standard issue clinician at the bedside, and that looking at the patient in front of you, understanding the pathophysiology that the patient is being exposed to, and then understanding the science, and then sort of formulating a plan based on all of that. So in my practice, and I think a lot of the folks, Tom, et cetera, that I talk to about these issues with using high flow for hypercarbic ventilatory failure, is that, you look at the patient, if the patient is awake, appropriate, mildly hypercarbic, mildly increased work of breathing, then high flow nasal cannula would be my go-to. I wouldn't even probably think about non-invasive or BiPAP for that patient. However, the patient's fallen asleep on me. I've done a blood gas and they're fairly acidemic and they're hypercarbic, and then that might not be the person that I start high flow. And I might start BiPAP and then segue into high flow later on in their course when we've got a handle on whatever's causing their exacerbation to begin with, right? So I think it's important for the listeners to understand that they need to formulate a plan based on what's in front of them, not on all the numbers that they've seen it in these trials necessarily.
Yeah, and Thomas mentioned a while ago some of the caveats about taking randomized controlled trials too literally. But another one is the patients in these randomized controlled trials are selected based on well-defined criteria that are supposed to give you as much as possible a homogeneous population, which in humans is in biology is impossible.
Correct. Yeah.
But you keep in mind that the patient you're dealing with may not have been represented in the trial. So
Yeah.
Most
this is the
likely
case
weren't,
with this
right?
is the case with every
Yeah.
pregnant patient I've ever had in the ICU. Someone's like, is it okay to give a pregnant woman BiPAP? And it's just like, well, they're excluded from every study, so technically we don't know. but physiologically, it makes sense to try it instead of
But we're gonna
intubating.
find
But
out, aren't we?
yeah, we're gonna find out. But it's yeah, it's one of those things. For example, it's like you get a patient whose BMI is over 40, and you're just like, should we do this? And it's like, well, these patients have all been excluded from the trials that we're asking the question of here. So we need to just be understanding of the physiology, understanding of the patient, and recognize tolerance or intolerance of whatever we're trying to do. Right? So yeah, there's always those patients that are just we actually don't know the answer to the question simply because research is designed in a way to try to make everything accurately comparable. And you can imagine that the groups they're excluding are usually groups that aren't as represented in the typical ICU population. Like we don't have a lot of pregnant women in the ICU. Depending on your ICU, you may not have a lot of patients with a BMI over 40. Some ICUs you might. And those are the ICUs that you probably should do some specific studies with that population because the RCTs that are being published are not really designed for those subgroups of patients.
Well, that's particularly true in the ICU. I've been in a number of ICU trials where when you exclude all the patients based on all the exclusions, it turns out that 5% or less sometimes of the patients you screened actually are eligible for your trial.
Yeah,
So
there's
that
nobody
means
left. Yeah.
95% of the people who supposedly have what it is you're targeting never
Yeah.
got into the
Don't meet
study.
the criteria. Yeah. Yeah. No, it's true.
So I wanted to make sure that we got to this point, Nick. So we've talked about non-invasive support for hypoxemic respiratory failure. We've talked a little bit about, or even more maybe, about non-invasive support for hypercarbic ventilatory failure. There are certainly patients that have both. There are certainly etiologies that are different amongst patients: asthma, COPD, pneumonia, sepsis, etc. Something that's really common today, though, is the extubation to non-invasive support. It's common in my practice. I'm more likely to extubate somebody to non-invasive support than I am to not do that these days, even if there's even a whiff of a chance that they're at higher risk for reintubation than the standard patient. What are your thoughts on that? And something that I sort of talk about a lot, but I'm not sure that I understand is how do I decide which support to extubate somebody to if I think they're I suppose it depends on what my concern is, but what are your thoughts?
Yeah, well, that's a great question, and talk about something that's been evolving in the guidelines. This is a good example. I don't put everybody I extubate on non-invasive respiratory support, whether it's most of them. It's certainly a substantial number. When you think about it, there are a fair number of people who, let's say they got intubated because they OD'd on something, and they didn't end up with an aspiration pneumonia, so they're pretty well extubatable and don't have a lot of secretions. They're oxygenating well. I probably wouldn't use anything on that kind of person, but I would have a low threshold. And so if I'm concerned about secretions, one thing that high flow provides is air conditioning. You get not only oxygenated gas, but heated and humidified, and that can help with maintaining mucociliary function and help mobilize secretions. And there is an effect on a little bit of reduction of work of breathing. So I would say more often my go-to is high flow because there are a lot of patients who are kind of, marginal oxygenation, secretions, still a little weak, but I think there is a role for non-invasive as well. I'm thinking we had a discussion about this on this guideline committee, and it's been very difficult to decide whether to say you should go with high flow or non-invasive. And I think it's a depends kind of situation. But if you have someone who's got COPD, hypercapnic COPD, and has severe involvement with a lot of expiratory resistance, I might lean towards non-invasive for that kind of patient. I mentioned the weak patient. That's another one where I might go with non-invasive to support them. So I certainly am an advocate of using non-invasive respiratory support in a significant proportion of people you extubate. You don't have to do it in everybody, and then you have to think about what your goals are when you select what modality to go with.
Yeah, there was the nice systematic review published in 2022 with Fernando. Were you part of that, Nick? Wonder if you were. It was in JAMA. I'm not
I
sure the
wasn't
full.
part of that one.
Okay, it was nicely done. Essentially showed like differences in number needed to treat, whether you extubated patients to non-invasive high flow or the combination of both. And essentially it was based on like risk scenario, right? So 10% risk, the success of high flow nasal cannula is even slightly better than going to non-invasive. Then once you get to like a 20% risk or like a 10% risk, they become much more close where it's like either or. But then when you get to the really high risk of like 40% risk of reintubation, NIV is the only one that they have data for essentially. But I think part of the problem is defining high risk, right? I feel like some people don't recognize high risk when it's staring right at them. And like high risk, for example, could be age over 65, history of COPD,
CHF.
pneumonia as the reason that they were intubated, or CHF is the reason. Like these are all like should be very clear scenarios that NIV might be the preferred option immediately post extubation. And then I think the other disconnect is clinicians not understanding that these therapies post extubation, the guidelines support the prophylactic use of them, not the rescue use of them. And I think this has been a disconnect since I've been in RT, that people just think non-invasive post-extubation is okay. It's like, no, no, no. It's the prophylactic use. If you're trying to rescue patients, the data is clear that that's likely not the best idea, mostly because it delays reintubation in those patients. And those patients end up doing worse once they're reintubated. That disconnect, I think, is always something that's, I feel, a necessary push to clarify anytime I give a talk on this, which ironically, I have a talk on this specific subject coming up for Phillips this month. But yeah, it's one of those misconceptions, I think, that they hear guidelines, oh, non-invasive post-extubation is a thing we should do, but they neglect the fact that if they were on standard nasal cannula after extubation and then they fail 8 hours later, this is not the same as prophylactic use.
Yeah,
Yeah.
geez, I definitely endorse using it prophylactically, and also not only agree that the literature suggests that delaying intubation and trying to catch up for lost time with non-invasive support is probably not efficacious.
I'm still
I wanted to
surprised
hit.
how many times I hear that order though. Like
I know,
someone
I
failing
know.
8 hours later is like, can we try BiPAP? I'm like, should we maybe
No,
just reintubate? I don't know. This might not be a good
gosh,
idea.
we did our best, man. We got him extubated. We took it. We took the chance. Hey, listen, I want to. I want to just make sure we talk about one more thing. I can't get over this pneuma belt, Nick. I can't get over. So I love the idea. However, today I hear a lot of advertisement for this portable negative pressure ventilator.
Yeah, the Hayek.
Yeah. Well, I wasn't going to say. I wasn't going to say that, but yes, that's what I'm talking about. They very enthusiastically support the use of this even in acute and critical care. And I want to just see what your initial thoughts are.
Since this is a public forum, I want to be careful here, but the Hayek has been around, let's see, since the late 90s. Initially, it was developed as a negative pressure ventilator, and Respironics purchased the rights to the Hayek in the US around that time, and they wanted to develop it, find a market for it, and it just pretty much fell flat on its face. And it was illustrative of my experience because, as I mentioned, I started out using these so-called body ventilators, called body ventilators because they put pressure on different parts of your body to help you breathe. And there were so many advantages of positive pressure as opposed to negative pressure in terms of just the convenience of use, the control you get over the ventilation. We published an article in Chest in the late 1980s that showed that the iron lung negative pressure ventilation promoted obstructive apneas because if it wasn't cycled with the respiratory cycle, so if the patient was inhaling when it wanted to draw air in, it would close the glottis, and you get an obstruction. And negative pressure ventilators will do that. So, and also it's a little clunky, a little more effort to get on people, I would say. The device that powers it is not easily portable. It's not, a little respiratory assist device. So there are a lot of potential disadvantages. And so it just didn't take off. But they've tried to reintroduce it like every half a dozen years with some other iteration. So now they're talking about a vibratory form, and it will help clear secretions, and you could also use it to ventilate. And I don't see it going anywhere again.
Yeah. Yeah, all things that I've thought as well. Tom, did you have
No, I
I mean, I've
agree.
never used it, but I've only heard people say the same things that Nick has just said.
Anytime I hear something getting more traction when it's already been around, I'm like, I always ask the question, has the evidence changed? Is there new evidence supporting this? And what kind of evidence is it? And if it's not convincing enough, it's not going to change my practice. It's not going to, I'm not going to allocate money to purchase a device unless there's a strong reason to do it. When we have guidelines, as we've been talking about, supporting certain therapies already. And yeah, so I always say, show me the data.
Yeah, there Antonio Carrero, I think Carrero was his last name. He was an Italian friend of mine. He was from Florence, and I became particularly good friends because he invited me over to Florence to give talks for about 5 years in a row at his conference. But he was using a what looks like an iron lung, but I don't know if you're familiar with the porta lung, but it was a kind of a scoped down version of an iron lung. It had plastic components rather than metal, and they had these in his unit in Italy, in Florence, Italy, and so he published a number of studies on use of this in people with COPD to treat acute exacerbations, and it worked. But again, one of the big problems with the iron lung, they're generically referred to as tank ventilators, is you don't get access to the patient's body. Their head is sticking out of a neck seal. And so if you want to get at the body and provide nursing care and maintain IVs and things like that, you have to jump through extra hoops. And so it can be done, but it's inconvenient. You're not going to talk your nursing staff at most hospitals into dealing with these things. I don't see it as really, I don't see a viable pathway for this. If someone wanted to be a champion at a given institution and really twist arms to use it, you could probably get it done that way, but not many people are going to go to those lengths.
Yeah. Well, that seems like a good place to wrap this up. I appreciate you, Nick. I really appreciate you. Thanks for sharing your insight and expertise today. And thanks to the listeners for joining. And please share our podcast and, of course, join us for next week's episode. New episode teasers are posted every Friday, and the full episode is published every following Monday. Don't forget to check out our website for other resources and opportunities at www.inspired. All right, Nick, we appreciate you. And
Yeah, thanks very
hope to have
much
you.
for having me, Keith and Thomas, and
Thank you.
happy to do it anytime. I know
Yeah.
it seemed like I was reluctant, but I didn't have your
Hey,
will.
we made it
Scheduling
happen.
issues there. Yeah,
We
we made
made
it
it
happen.
happen.
It worked.
And I'm glad we did. This was a great talk. I appreciate you guys. Have a good afternoon. Okay.
Thanks so much.
Likewise.